Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Rod, and today we're diving deep into one of the biggest public health challenges out there, chronic low back pain. Now, have you ever wondered why nearly 84% of people experience low back pain at some point in their lives, yet we still struggle to pin down exactly what's causing it and how to treat it effectively? Buckle up, because today we're going on a journey through the latest international guidelines on diagnosing and conservatively treating non-specific chronic low back pain. Chronic low back pain, or CLBP, isn't just about an ache in your back. It's a major cause of disability, work absence, and even long-term economic and social burdens. In fact, it's one of the leading reasons people end up on sick leave and is a huge factor in work disabilities worldwide. And yet, we're often left with a diagnosis of non-specific low back pain, meaning we haven't pinpointed a clear pathoanatomical cause, which makes targeted treatment tricky. Today's episode is all about unpacking a narrative review that combed through international guidelines from Canada to France, Germany, the UK, and the USA to give us a comprehensive look at how we diagnose and manage chronic low back pain without a clear underlying cause. And if you're a patient or a practitioner, there's plenty here that can help guide treatment decisions. Let's start with the diagnostic part. When we talk about low back pain, we need to consider its duration. It's classified as acute if it lasts less than 2 to 4 weeks, subacute from 4 to 12 weeks, and chronic if it goes on for more than 12 weeks. The 2021 French guidelines even introduced the term acute LBP flare-up, highlighting that even in someone with chronic pain, there can be sudden exacerbations that might need a temporary boost in treatment. But here's where it gets interesting. Since low back pain is often labeled as non-specific, we don't have a clear pathoanatomical diagnosis. Instead, international guidelines suggest looking for red flags, warning signs like symptoms that might hint at cancer, infection, trauma, or severe neurological deficits. At the same time, we also need to hunt for those psychosocial risk factors, sometimes called yellow flags, as well as blue and black flags. These aren't just buzzwords. They're about identifying fears, beliefs, work-related stress, and even depression that could predict a higher risk of chronicity. Tools like the START back screening tool and the Urabro musculoskeletal pain screening questionnaire are recommended to help stratify risk early on, usually after about 2 to 4 weeks of symptoms. The idea is to figure out as early as possible who might go on to develop persistent disability. And while the clinical examination and patient history are vital, it turns out that even these can be imprecise when used alone. Now, let's talk about imaging. This is a hot topic. Most guidelines agree that in the absence of red flags, routine imaging isn't very helpful. Why? Because imaging findings often don't correlate with the patient's symptoms and can even lead to unnecessary treatments that might worsen the problem. However, the 2021 French guidelines do recommend an MRI if the low back pain persists for more than 3 months. X-rays, on the other hand, are generally only useful if we suspect instability, like spondylolisthesis, or want to assess spinal alignment. The bottom line here is, unless there are clear signs of something serious, we should avoid over-relying on imaging tests. All right, now for the meat of the discussion. Treatment. The international guidelines we're looking at agree on one thing. Multimodal management is key. That means combining non-pharmacological and pharmacological treatments, all tailored to the individual. Non-pharmacological treatments 1. Exercise therapy and physical activity. Every guideline out there champions exercise as a cornerstone of treatment. Whether it's aerobic exercises, water-based programs, Pilates, yoga, or Tai Chi, staying active is essential. For example, the Canadian guidelines suggest starting with gentle exercises and gradually ramping up the intensity as long as it's within your pain tolerance. And hey, if exercise makes the pain worse, that's a signal to get a qualified physical therapist involved to tweak your regimen. Number 2, physiotherapy and manual therapies. Physiotherapy is recommended as a first-line treatment for chronic low back pain. Techniques like spinal mobilization or manipulation can be used, but only as part of a broader treatment program that includes exercise. Interestingly, while massages and soft tissue techniques can be a helpful add-on, evidence shows that adding massage to an exercise program doesn't always offer extra benefits over exercise alone. Number 3, psychological treatments. Let's not forget the mind-body connection. Cognitive behavioral therapy, CBT, is frequently recommended in combination with physical therapy. This approach helps address the fear avoidance behaviors and psychological distress that often accompany chronic pain. Some guidelines also mention mindfulness-based stress reduction, progressive relaxation, and even electromyography biofeedback as useful adjuncts. 4, patient education and self-management. All the guidelines underscore the importance of educating patients. You need to know that maintaining activity levels, getting back to work or normal daily routines, and understanding the nature of low back pain are crucial. This isn't just about throwing pamphlets at you. It's about giving you the tools to manage your condition effectively and counteract any catastrophic thinking about pain. Number 5, multidisciplinary rehabilitation. For patients with significant psychosocial obstacles or those who haven't improved with primary care alone, a multidisciplinary approach is advised. These programs combine physical rehabilitation with psychological and sometimes occupational interventions. The goal is to provide a structured, community-based program that helps improve both physical function and mental resilience. Now, let's talk medications, because sometimes you need a little extra help when the pain flares up. 1, oral treatments. NSAIDs. Almost every guideline recommends non-steroidal anti-inflammatory drugs as the first-line option. The key here is using the lowest effective dose for the shortest duration possible. For instance, while the article doesn't pin down exact doses, a typical regimen might be something like ibuprofen 400 milligrams every 4 to 6 hours as needed, always with caution and under your doctor's supervision. Acetaminophen. There's a bit of controversy here. Some guidelines list acetaminophen as a first-line treatment, while others advise against it when used alone. So, if you're considering it, remember that dosing generally follows standard recommendations, say 325 to 1,000 milligrams every 4 to 6 hours, not exceeding 4,000 milligrams per day. But again, individual factors matter. Weak opioids. If NSAIDs aren't cutting it, or if they're contraindicated, weak opioids might be used as a second-line option, sometimes in combination with acetaminophen. The guidelines are clear about the risks. These should only be used when absolutely necessary and for the shortest time possible. Specific examples in the literature mention agents like tramadol or even duloxetine in some cases. However, exact dosing isn't set in stone here because it must be tailored to each patient's risk factors and response. Always check with your physician to ensure safe usage. Other oral medications. Muscle relaxants, tricyclic antidepressants, and anticonvulsants are mentioned in some guidelines, but their use is controversial, and many guidelines advise caution or outright not recommending them as part of routine management. 2, topical treatments. Capsaicin. Topical capsaicin is noted as effective over a short period for managing pain. It's a neat option if you want to avoid systemic side effects. Lidocaine patches. Now here's where opinions diverge. Some guidelines, like the 2021 French and ACOM, advise against using lidocaine patches, while the Canadian guidelines are more in favor. So if you try them, do so with some caution. Topical NSAIDs. Their role remains unclear. Some evidence suggests they might help, but they're not universally endorsed. 3, spinal injections. Epidural steroid injections are generally off the table for chronic low back pain unless you have root pain, meaning symptoms that suggest nerve involvement. Similarly, facet joint injections aren't typically recommended. There is some nuance, though. For patients with suspected sacroiliac joint pain, intra-articular injections might be considered, and intradiscal steroid injections may offer short-term relief in cases with modic changes, those MRI findings that hint at active disc pathology. But overall, these interventional treatments are reserved for very specific cases. Now, you might be thinking, this is a lot to take in. How do we actually apply this in practice? That's the million-dollar question. One of the major challenges highlighted in these international guidelines is that the diagnosis of non-specific low back pain is, by nature, imprecise. Without a clear anatomical culprit, treatments can seem like a shot in the dark. And that's why there's growing emphasis on patient phenotyping, essentially looking at the whole picture. including biopsychosocial factors like fears, beliefs, and even work-related stress, to tailor treatments more effectively. The review suggests that for decades, despite numerous guidelines, chronic low back pain has remained a huge public health problem because our approaches haven't been refined enough. By better understanding the individual patient, through tools like detailed history taking, physical examination, and selective imaging when warranted, we might finally be able to offer more targeted and effective therapies. All right, folks, to sum it all up, chronic low back pain is complex. It's not just an ache in your back. It's a condition influenced by physical, psychological, and social factors. The latest international guidelines tell us that the best approach is multimodal. That means starting with non-pharmacological treatments, keeping active, engaging in tailored exercise programs, physiotherapy, and even psychological support like CBT. When needed, judicious use of medications like NSAIDs and, if necessary, weak opioids can help manage flare-ups, but always with an eye on minimizing risks. And remember, routine imaging isn't usually the answer unless you're seeing red flags or, as the French guidelines suggest, if pain persists beyond 3 months. We need to keep pushing for better diagnostic precision through patient phenotyping so that each treatment is as personalized and effective as possible. I hope you found this deep dive into the chronic low back pain guidelines as enlightening as I did. If you're a patient, I hope this helps you ask the right questions when you talk to your doctor. And for all you fellow healthcare providers, let's keep the conversation going. Share your thoughts, experiences, chef, and questions in the comments below. Don't forget to like, subscribe, and hit that notification bell so you won't miss our next episode, where we'll uncover yet another groundbreaking discovery that could reshape the future of medicine. This is Dr. Rod on Shock Doc Medical. Stay active, stay informed, and as always, keep questioning and exploring the wonders of medical science. Thanks for tuning in, everyone. Catch you next time.